This is Dr. Howard Strassler with a Hints from Howard on light curing. This Hints from Howard is a recap of my presentation of some important research evaluating the effects of resin contamination and damage of light guides on the light output of curing lights. This is part of a continuing collaborative research project that Dr. Richard Price and co-workers at Dalhousie University in Halifax and myself at the University of Maryland School of Dentistry are conducting. Light curing is important to the clinical practice of dentistry. The majority of directly placed restorations are light-cured resin-based composites. In fact, a 2011 survey of 100 dental schools reported that 63% out of the 46 dental schools that reported no longer taught the use of amalgam as the preferred posterior restorative material. When questioning dentists, it's apparent that dentists take for granted that their light curing device will reliably and predictably light cure the materials they are using. Also, every survey published has shown that dentists often use lights that are both damaged and are not reliable at delivering the energy needed to light cure their composites. These composite resins are put at risk. Our patients are put at risk. According to the most recent American Dental Association survey, an estimated 146 million composites and sealants were placed in the United States in 2005 to 2006. A report in the Journal of Adhesive Dentistry estimated that 261 million composite resins were placed in 2012. The durability of resin-based composites have come into question. In fact, even though reports have some composites lasting over 10 years in well-controlled clinical conditions by some very excellent clinicians, more studies have reported that the median longevity for posterior composites was only about 6 years. Very disappointing. Why aren't composites lasting longer? We know that there are so many factors that contribute to how long our composites last. The patient's oral history, their habits, their risk of caries. Us as the operator, how we're placing our restorations, how we isolate the field that we treat in, the size and location of the restoration we're placing, the effects of polymerization shrinkage, and the energy that we deliver from our light curing unit to cure a composite are all important considerations when we look at how long restorations last. These factors are usually well controlled in clinical trials that report excellent longevity. But these clinical trials many times don't mimic how these restorations are placed in practices. We have to do better. In order to understand how light curing works, one has to understand the terminology for quantifying energy delivered to our restorations. When evaluating curing lights, the researchers, clinicians, manufacturers need to be on the same page. Typically, the value reported for curing lights is irradiance, milliwatts per square centimeter. There's a lot more to curing lights and the energy that we need to cure our composites. It's also been reported that, and from what I've seen in many private practices, that there's resin contamination and damage on the tips of many curing lights. What does that mean to our ability to cure our composites? This study examined the effects of resin contamination and damage on the ability of a curing light to do their role, curing composites adequately. For any research, there needs to be a deliberate protocol that's designed and followed to gather the data to evaluate the hypothesis. For this research project, the hypothesis was that contaminated and damaged light guides can have a negative impact on the power output of curing lights. This negative impact will also affect the ability to light cure our composite resins for our patients. We measured the radiant power over distance using a laboratory-grade thermopile, and you're seeing a picture of that instrument being used with the light tip on a Optilux Dematron 501 curing light. We looked at the effect of distance on the percent of maximum power. What's important is that for most Class II restorations, the gingival margin of the composite needs to be cured to at least 6 millimeters. Look at the power drop-off at 6 millimeters in this graph. It is striking. We also looked at the beam profile for each light tip. The beam profile describes the irradiance value, radiance energy, over the surface of the light curing guide. The red areas of those beam profiles have the highest irradiance, which is good. The violet and blue areas have much lower values. Let's look at some of the light guides we tested and how the beam profile correlates to the physical appearance of the contamination and the damage on the light guide tip. You're going to see some very powerful images. For the first light guide we tested, there was no damage or debris on the surface. I mean, this guide is almost factory fresh. For light guide 2A, notice the significant debris on the surface and the dead zone that corresponds to that debris. Anywhere there's a dead zone, it's an area where there's no light energy getting to the tooth restoration where the composite resin is being placed. Once again, the dead zone and reduction in irradiance that correlates to the resin contamination. Hopefully you're not using a light guide that looks like these. These light guides were being used by dental students. It's representative of the lack of use of barriers on the light guide that can cause contamination of composite getting on those light guides. Also, in some cases, the lights were dropped and the tips were damaged. In preclinical laboratories, typically barriers aren't used. But in the clinical setting, you need to use barriers over those light guide tips. You can even use saran wrap over the light guide to protect the tip from cured composite getting on that tip end. The results of this study is very striking. It's what you would have expected. Debris and damage on the light guide significantly reduced the radiant power output by around 21%. Radiant power output from the light guides at 6 millimeters, the distance away from the light guide tip, had a 33% reduction. At 8 millimeters distance away, we had a 45% reduction. Because of this reduction of radiant energy being delivered over distance, you can consider when curing the proximal box of a Class II restoration, you should increase your time for curing the composite. This is especially true for bulk fill composite restorations. As you increase the curing time, it's important to cool the tooth with an air stream. That increased curing time will create more heat to the tooth and to the pulp. Even though some light guides had similar power values, and these two light guides, one's listed as 568, the almost new light guide on the left, and you compare it to the light guide where there's contamination, which has a power of 538 milliwatts, that you notice that there are hot and cold spots of energy delivery, even though the readings seem similar. Many dentists use radiometers, either on their curing lights with built-in radiometers or using a handheld device. In most cases, it's your chairside assistant measuring and recording these irradiant values onto a log on a monthly basis. These devices, while useful to monitor changes, usually have smaller apertures and small detectors. In many cases, the apertures are anywhere from 4 to 8 millimeters in diameter. The red circles on these images on the beam profiles define where the light would be measured if your chairside assistant placed the light guide centered on the handheld radiometer. For these two light guides, the irradiant values would be measured very similarly. Yet the irradiance doesn't tell you the full story. Look at the way these light guides are giving out the energy to cure a composite. The one on the right is significantly different. The irradiance doesn't tell the full story. You need to be vigilant. you need to check your light guide tips. If they're damaged, replace them. If they're filled with debris, clean them. If you can't clean them, replace them. For this study, we proved our hypothesis. Debris and damage on a light guide can significantly reduce the radiant power output of a curing light. It's important to check the light guide on a regular basis, and if there is debris or contaminants, clean them off using alcohol. What I do is I leave the tip soaking in alcohol overnight, which makes the composite get softer. It makes it easier to remove it from the surface. I can then remove the debris with my fingernail or using a plastic spatula. I don't use a metal knife. On those surfaces, I don't want to create any damage. A clean and undamaged light guide tip will allow for an optimum effect on the energy being delivered to your composites. When you get your light, to avoid this problem, start using barriers on a routine basis. You won't have these problems. This presentation was from the latest research on light curing from the IADR in Boston this past March of 2015. Thanks for watching and listening.